All right, guys. Good morning. Uh, Mohammed here. I'm gonna talk a little bit about drug-induced liver injury. Obviously, this is by no way. This will not cover every single drug-induced liver injury, but mainly pretty important patterns and pretty important things that we need to know for our boards and for our clinical life in the future. And thanks to Dr. DeLeo, he really helped me a lot during this presentation. It's a tough topic. So I'll start. I'm hoping it will be eventually interactive, but we'll start by some terminology, a little bit of background. So some of the terminology used when we talk about drug-induced liver injury are the following terms. So latency, it just means what is the timing of the onset of the injury after which the drug was started. Another important term is de-challenging. And as it sounds, it just means that once you stop the drug, there is resolution of the drug-induced liver injury. Re-challenging just means that there is a recurrence of the injury after re-exposure to the drug. And then finally, likelihood. This is just the likelihood of the actual medication or previous reports, the potential hepatotoxicity of the drug itself. And then finally, the phenotype and the type, which we will talk a little bit more, but it just means that what's the clinical or pathophysiologic features of this drug-induced liver injury. And just to get this out of the way, obviously liver tox is your friend. A very interesting statistic that I saw from liver tox is that among almost 1,000 prescription drugs described, almost half of them, 46% of them, are implicated in liver injury, at least in one published case report. So there's no point in memorizing all the drugs that can cause, because it's a 50-50 chance that it's going to cause liver injury. But it's important for us to realize how to tease that out. Let's talk a little bit about the mechanisms of injury. So as you know, when you take a drug, either PO or IV, eventually it'll end up in the liver. So eventually it'll get into the sinusoids and it'll be uptaken by the hepatocytes. And during this process, or in the hepatocyte itself, the drug can cause a number of things. It can cause mitochondrial impairment. It can inhibit the biliary efflux or biliary secretion. It can cause lysosomal impairment. The drug itself can be metabolized, and it can produce reactive metabolites that can eventually lead to chemical, oxidative, or protein modification stressors on the hepatocyte itself. It can also induce this very famous kind of pathophysiologic mechanism called endoplasmic reticulum stress, which will affect the hepatocyte production of proteins and metabolism. And then finally, the drug itself or its metabolites can induce an immune reaction in the form of innate, adaptive, or an inflammatory response. And then eventually, one or a number of these mechanisms will end up with the type or phenotype that we end up seeing in liver injury. If you really zoom in on the hepatocyte and you see what happens is, the drug gets uptaken here from the blood vessel. So this is the hepatocyte, this is the blood vessel, and then right here is the the biliary side. And so the drugs get uptaken by the hepatocyte, by all these transporters, and it can undergo oxidation, conjugation, phase 1 and 2. And the metabolites of the drug can be reactive, and they can induce cell stressors, as we mentioned, can also induce an immune reaction, but also can go ahead and block the secretion of bile acid, which may end up in cholestasis or cholestatic hepatitis if it also induces an immune reaction. Again, there's no point in memorizing every single transporter. Just knowing the general concepts of how the injury occurs is more important. Another very important concept when we talk about any liver injury, to be honest, is to realize that one of the main classification of the liver histology is the lobular histology, or you classify the liver as different lobules with a central vein in the middle and surrounded by hexagonal portal triads. So you've got the portal vessels coming through here, and then the sinusoids, and then you've got a central vein in the middle. And then the zones it's these area from the portal to the central vein, they're called zone 1, zone 2, and zone 3. Other people like to call it periportal, pericentral. Okay. What's important to know is that different injuries to the liver can occur at different zones, and different drugs may occur at different zones. We will talk about specific examples. So let's talk about the types of drug injury, and then we'll talk about a little bit about the phenotypes or clinical phenotypes. When you think about drug-induced liver injury, so you can think about it in a couple of ways, but this is one of the important ways to think about. You can imagine that the drug itself may have a direct hepatotoxicity on the hepatocyte. And this also can be called intrinsic hepatotoxicity of the drug itself. The other one that is important for us to know, and you will hear about it a lot, is idiosyncratic hepatotoxicity. And it's just a fancy word of an unexpected reaction or an unusual outcome. So this is not an expected direct hepatotoxicity of the drug itself, but so it's more of an unusual reaction to the drug, can be manifestation from the environment or the patient's own genetics, epigenetics. So it has a lot of influences. Why would this idiosyncratic hepatotoxicity occur? And then finally, an indirect hepatotoxicity, which just means that the drugs, not itself, but maybe its metabolites, can induce the toxicity or can induce an immune reaction and end up in an inflammatory kind of injury. The other way to think about both of these three things is to think about the direct and indirect injury as toxicity from the drug itself. So the drugs that cause these, you can refer to them as hepatotoxins, while the drugs that cause an idiosyncratic liver injury can be hepatoallergens, because it's somewhat of an unusual reaction that happens. Important to note that one drug may be able to induce multiple kinds of injury. It's not just one drug induces one injury. Again, this is a nice table that I got from a New England Journal article, and I'll send the articles and the resources that I use for this lecture afterwards. But essentially, when you look at a direct hepatotoxicity, as you imagine, this is a dose-related hepatotoxicity, because the drug itself is causing the liver injury, and so the more doses you give, the higher the hepatotoxicity. While the idiosyncratic and indirect hepatotoxicity, it's really not dose-related. The direct hepatotoxicity is also predictable, while what's important is that this idiosyncratic hepatotoxicity is unpredictable. And very important to remember is that direct hepatotoxicity usually happens within days. Indirect takes months, but idiosyncratic hepatotoxicity, and that's an important thing to remember, it can happen anytime. Days to years later, you can get hepatotoxicity. We'll talk a little bit about phenotypes. So while I was trying to do this lecture, I tried to, put in all the phenotypes, but then it ended up being boring. So I'm just gonna go through cases, and maybe if you guys can hop in, that would be great. You can also chat. You can throw in the chat what you guys think. Okay. So let's start with this case. Case number 1. So this is a 40-year-old female who has small bowel Crohn's disease. Was diagnosed 3 years ago. Initially treated with steroids. And then was started on azathioprine, which may or may not be a monotherapy azathioprine nowadays. In any case, started on azathioprine, 100 milligrams daily for the past 3 years. She now presents with epigastric abdominal pain, and they do some labs, and notable for a platelet count of 50. And even though the AST and ALT are normal, I highlight them because the AST is higher than the ALT, and this sometimes can indicate cirrhosis, especially if other things go with it. And so obviously you do right upper quadrant imaging, and they end up doing a CT abdomen pelvis because of right upper quadrant imaging showed some ascites, and the CT abdomen pelvis shows splenomegaly, an enlarged portal vein, and the gastroesophageal varices, as well as a nodular contour of the liver. The patient also got an endoscopy that confirmed the presence of small to moderate varices. So this patient ends up getting a liver biopsy. Obviously, A is just a demonstration, and this whole thing is demonstration of what it would look like if you looked at the liver. And her liver looks like, grossly, looks nodular or micronodular, really. These are nodules that are 1 millimeters. And on B, you can see there's these kind of organized nodules in the liver with areas of what looks like maybe necrosis. We look from here. And then on C, this is the trichrome stain. And you know, when we do a trichrome stain, we're staining for the.
Often using this thing. I just want to make sure.
Sorry, can you guys mute yourselves? Thank you. When you stain for trichrome, you're looking for fiber deposits. And as you can see here, there's no fiber, or there's no fibrosis. And this, again, this rules out cirrhosis, right? Even though it kind of looks like cirrhosis. And then finally, when you stain for reticulin, specifically, you see these reticulin fibers surrounding this nodule in the liver. Anybody can throw the diagnosis? What do you guys think? So this is a patient who's been on azathioprine for 3 years.
Is it focal nodular hyperplasia?
Yeah, exactly. Perfect. So this is what we call NRH, nodular regenerative hyperplasia. It's a form. It can be a form of drug-induced liver injury, but it also can be a form of a manifestation of other diseases. It's really the micronodular transformation of the hepatic parenchyma, and this is mainly due to blood flow alterations. And you can see the end blood flow to the liver can be altered, and you end up with these nodules throughout the liver. Important, this is not cirrhosis, but because it causes compression at the surrounding parenchyma of the liver, these nodules start causing compression of the sinusoids. It can cause essentially an intrasinusoidal portal hypertension. And this is what we call non-cirrhotic portal hypertension. This is associated, again, with some drugs. The notable drugs are azathioprine and 6-TG, as well as bleomycin, doxorubicin, busulfan, but also it can be associated with rheumatologic conditions such as RA, Felty syndrome, SLE, and some hematologic conditions such as ITP and polycythemia. It can also be congenital, but I doubt that we will see this. The important part is how to treat this. So two things. To treat it is you have to treat the underlying cause. If you have hematologic or rheumatologic malignancy, you treat the underlying cause. And if it's a medication, you really need to withdraw the medication if possible. What's good about this is that the natural history of this is really indolent and doesn't end up with needing a transplant or something. And it rarely causes decompensated portal hypertension with variceal bleed and stuff. So this case was a little exaggerated. It's usually can be clinically significant or insignificant portal hypertension. But again, when you see a nodular contour of the liver, it's not always cirrhosis. Think about this. All right, let's move on. Case number 2. A 48-year-old female with myelofibrosis, status post stem cell transplant 1 week ago. Now presents with jaundice and weight gain. Her ALT is 52, her ALK-Phos is 74, and her T-bili is 14.4. They do a right upper quadrant ultrasound that shows moderate ascites. Due to the injury, a liver biopsy eventually was obtained. The biopsy shows congestion and hemorrhage in zone 3, so pericentrally. There is congestion of hemorrhage with spillage of red blood cell between the hepatocytes, as you see here. And this change is associated with hepatocyte necrosis right here. And this is the central vein, this is the portal vein. What do you think is happening?
Hi, Mohammed. I'm surprised that this patient did not have Jamaican bush tea, but this looks like SOS.
Right, SOS, right? Sinusoidal obstruction syndrome. So sinusoidal obstruction syndrome, also called veno-occlusive disease. Remember, this is very well associated with stem cell transplant. This is really the main, when they first described it, it was described as a post-stem cell transplant or bone marrow transplant problem that is due to mainly the medication, the alkylating agents that sometimes they give around the bone marrow transplant. And so this is associated with some drugs, specifically chemotherapeutic alkylating agents, busulfan, cyclophosphamide, dacarbazine, and some platinum compounds that we may encounter: oxaliplatin, carboplatin, and cisplatin. But also, my favorite, it's associated with Jamaican bush tea. In fact, I think the first case that was described of this was like in 1960 or something, and it was described in a Jamaican population drinking the Jamaican bush tea. Okay. How to diagnose this? There are two different criteria, but really they're pretty similar. There's the modified Seattle and the Baltimore criteria, and the diagnosis is really having a very elevated bilirubin. And they describe it in the context of a stem cell transplant, essentially. So you need a bilirubin above 34 with hepatomegaly, ascites, and weight gain of more than 5% from the pre-transplant. Because this is becoming kind of more common, people are realizing this. They're actually using ursodiol prophylaxis prior to bone marrow transplant to try to prevent the development of SOS. But if the patient eventually develop it, then really the treatment is supportive care. There is some data about using N-acetylcysteine and difibrotide, which a lot of centers actually use once patient develops sinusoidal obstruction. If you read all the case reports, they've been using difibrotide, which is an antifibrotic, antifibrotic and antithrombotic activity or thrombolytic activity. Rarely does it require a transplant. All right. Any questions about this? I'll move on to the next case. All right, let's keep going. 21-year-old male with acne was started recently on minocycline 2 months ago. Now presents with fatigue, dark urine, jaundice, and weight loss. His ALT was 1300, ALK Phos is 780, and T-bili is 5.7. You do the chronic liver disease workup or the usual stuff that we send, and then you find that the ANA is 1 to 1200. You end up getting a liver biopsy, and the liver biopsy shows few things. The liver biopsy shows interface hepatitis, which is manifested here by an infiltrative lymphocytosis in the pericentral, in zone 2 essentially. You see loss of typical sinusoidal structures here, and a periportal lymphocytic inflammation surrounding the portal vein, and then finally some lobular inflammation around the lobules. So what is the diagnosis here? So started on minocycline 2 months ago, now with interface hepatitis.
So this is still DILI, but there's a limited number of medications that can give you an autoimmune hepatitis picture that's caused by DILI.
Exactly. So this is essentially an acute hepatitis with an autoimmune features. Another word, you can call it a drug-induced autoimmune hepatitis. There are some notable drugs that you should know about. Specifically, minocycline is like the one notable that I saw come up over and over. But also hydralazine. Again, this is notable to induce drug-induced lupus and can induce drug-induced autoimmune hepatitis. Other ones include infliximab and interferon. There's no established.
I had a question on the ACG for nitro too, so that's just something to be aware of. Nice. I know you have it listed.
Perfect. Antibiotics in general is just be aware of antibiotics when you talk about DILI. There's really no established criteria when I was looking, but really you can use the criteria of autoimmune hepatitis because it's kind of the same thing. It induces an autoimmune reaction that you can use autoimmune hepatitis criteria to diagnose, but you really also should use your clinical sense. The treatment, as a lot of drug-induced liver injury, is de-challenge. Stop the medication if possible. If there is no recovery in 1 to 2 weeks, you can start steroids. The important point about drug-induced autoimmune hepatitis, or autoimmune hepatitis in general, but specifically drug-induced autoimmune hepatitis, do not stop steroids until full recovery. From the few cases and the literature review that I've done, people who stop steroids prematurely for drug-induced autoimmune hepatitis have bad outcomes. They end up with transplants or high mortality rates.
Mohammed, just one point here, because this is a favorite and this comes up clinically also. Virtually every drug-induced liver injury can end up with autoimmune hepatitis, even seronegative. You know, when you do the liver biopsy in the later stages, the hepatopathologist will read it as autoimmune hepatitis. You would argue with them, no, this is autoimmune, you know, the patient had this, there is no serologic tests that are positive. It still is an autoimmune event at the end. And one word on steroids, if you have a patient who is going into liver failure and it reached the point of no return, don't give steroids. You know, that's gonna just increase the peri-op infection risk and mortality. It's a really tough judgment call when you will reach that point of no return, but this is one of the toughest parts of dealing with drug-induced liver injury. Hopefully you can catch it earlier so that you have time to intervene with steroids.
Thank you, Dr. Eidelman. All right, moving on to case number 4. 42-year-old female with a history of gout on allopurinol now presents with fever, a maculopapular rash, and jaundice. Her AST is 1300 as well as her ALT 1100. Alk Phos is 1100, T-bili is 13.5, and the INR is 3.1. I'm going to show you the rash that she had. So it's a maculopapular rash. And you end up doing a liver biopsy. The liver biopsy shows an extensive centrilobular necrosis, so zone 3 and zone 2 and zone 3, essentially zone 3, with fiber collapse, and the specific feature here is prominent eosinophilia. So there's a lot of eosinophils throughout this necrotic region. There's also some sinusoidal dilation right here. So what is the diagnosis?
Is this DRESS syndrome?
DRESS syndrome, correct. So this is drug reaction with eosinophilia and systemic symptoms. Very notable drugs that can cause this is some of the anticonvulsants, carbamazepine, phenytoin, but also allopurinol, and again, minocycline and vancomycin. This is not vancomycin red man syndrome. This is a different one, right? This is DRESS. The latency is usually 2 to 8 weeks, and clinically, there's really a clinical diagnosis of there's clinical criteria. You can look it up. It's called the Regi-SCAR criteria, kind of beyond the scope of this lecture, but clinically, you see fevers, lymphadenopathy, and eosinophilia peripherally, plus liver, kidney, cardiac, or pulmonary involvement. That's how you suspect it. Plus the typical maculopapular rash. Again, there's like certain points on this criteria, and then if you score it, it's probable. The important for us to remember is that DRESS is associated with certain drugs and certain population, people with certain HLA variants. One notable one is the Han Chinese with B5801, HLA B5801. They're kind of allergic to allopurinol. They're high propensity of getting DRESS from allopurinol. There are others here that we probably should know about. Just keep in mind, we shouldn't memorize them, but just keeping them in mind.
Mohammed, is this female predominant?
Not necessarily. I didn't see anything about female versus male. We've seen a case here in county that was in a Hispanic male, and I forgot what was the drug. So the treatment is, again, de-challenge. For mild cases, you can just use topical steroids for the rash if that's the problem. But once you get liver involvement, you get like kidney involvement, you get a severe case, then you can use systemic steroids. and not always have good outcomes. And if that doesn't really work, then you can use second-line therapies as other kind of autoimmune or inflammation, immune-mediated reactions. You can use cyclosporin, IVIG, or tofacitinib to treat this. All right, we'll move on. Case number 5. This is kind of a favorite. So 71-year-old female with history of hyperlipidemia on simvastatin. Switched recently to atorvastatin 80 milligrams daily 6 weeks ago. Now presents to the PCP and has elevated liver enzymes. Previously were normal. An ALT of 262, an ALK phos of 694, and a T-bili of 0.5. So what are you gonna do?
I would stop Lipitor.
Stop Lipitor. Would you switch to something else?
I can switch it to rosuvastatin
Rosuvastatin.
because Lipitor is lipophilic
Okay.
and Rosuva is hydrophilic.
Okay, so he says he switches to rosuvastatin because of lipophilicity and hydrophilicity of rosuvastatin. Correct. You switch the atorvastatin. Here it was switched to pravastatin, which is de-challenging, and there's improvement. Once there was improvement, the patient was switched back to atorvastatin, and again the liver enzymes were elevated. So this is the re-challenging. So this proves kind of that atorvastatin was the culprit, and then finally was switched back to pravastatin indefinitely. I mentioned this case because it's important for us to remember what Faizan mentioned. There's a hydrophilic and lipophilic statins. However, I want to say that it doesn't really correlate 100% that lipophilic causes liver injury, hydrophilic doesn't cause liver injury. Lipophilic like atorvastatin, lovastatin, hydrophilic like rosuvastatin, pravastatin. I found a report from 2016 that looked at all statin-induced liver injury, and they essentially just calculated the number of cases and the positive rechallenge rate, and if there was a fatal liver injury. Number 1 was simvastatin, actually, had 68 cases. Atorvastatin has 65 cases. And then all the way down here, you can see lovastatin has 12 cases, and it was a negative rechallenge and never had a fatal liver injury, even though lovastatin is a lipophilic. So it's reasonable to switch to lovastatin too, if you had to switch. Pravastatin has little data. In fact, pravastatin is probably the weakest in terms of hyperlipidemia. And so if you want to switch, you probably want to switch to Rosuva or lovastatin, if that was the case.
So, by the way, just one comment on statins, because they are probably the most commonly used drugs, and we are seeing them so much. In elderly, usually everybody prefers rosuvastatin because of don't forget, the hydrophilic ones have less side effects, less muscle toxicity and what have you, not so much brain, but also they are weaker. My little granddaughter swallowed my rosuvastatin pills, and I don't even know how many of them she swallowed. I don't know how she got to the bottle, how she opened it. That's still to be whatever. But when I called poison control and I said it might be 4 or 5 pills at least, they said, don't worry about it. I am like freaking out. And I had to call a pediatric toxicologist who told me that nothing is going to happen. This is such a benign drug. I was really shocked, really. So toxicity is idiosyncratic and can happen with any one of them. I wouldn't necessarily switch one lipophilic to another lipophilic. Nobody dies when you stop the statin. I would have stopped the statin there and wait till it recovers and then give something lipophilic. But don't forget, lipophilic statins don't have the same impact on cardiovascular outcomes.
Got it. Thank you, Dr. Eidelman. Yeah, actually, there was a nice paper. I think the ACC recently concluded, and there was a nice paper of all the statins of what's the effect on LDL, and I think number 1 was rosuvastatin was the best one, kind of. A little thing about HMG-CoA reductase inhibitors, which are the statins. Some people who develop muscle injury or myositis, sometimes they develop these antibodies called anti-HMG CoA reductase autoantibodies. Again, these antibodies, we should just know about their existence. They don't correlate neither with the liver injury or the muscle injury. And in terms of the liver disease, this is what we need to remember. For chronic liver disease, for compensated cirrhosis, okay to use statin. They're safe. For decompensated cirrhosis, somebody with acute hepatitis, you're not going to start statin. But somebody with decompensated cirrhosis, you're avoiding statins here not because they cause more damage, but because people with decompensated cirrhosis were not live long enough to get the benefit that they need from the statins. So a lot of people, including the AASLD recent guidelines, advocate stopping the statins or not starting them in somebody with decompensated cirrhosis. All right, case number 6. 27-year-old male presents to the ER after a suicide attempt, an overdose of an unknown medication. Now presents with acute encephalopathy. This case is right from my simulator. And as you see, the drug was ingested here, between day 3 and day 4, and then the liver enzymes started going up into the thousands. So ALT is 10,000 now, AST is 5,000. We've got the T-bili is 4 and the INR is 3.4. Question is, what is the drug?
I'm sorry, is this your graph
Yes.
from your software?
Yes.
I love it.
Anybody? What is the drug?
It's Tylenol.
Tylenol. Yeah, it's a Tylenol, right? So this is a typical kind of presentation. You get very high elevation liver enzymes that can happen acutely, and this is Tylenol toxicity.
Hey, you have to use the generic names, not brand names.
So sorry, acetaminophen. You're right. Paracetamol, where I come from, they call it, but yeah, acetaminophen. So how does acetaminophen cause liver toxicity? So once the hepatocyte uptakes the drug, it's actually conjugated into a glucuronide moiety that is non-toxic. It also conjugated to a sulfate moiety that is also non-toxic. What is toxic is when the CYP450 2E1, this is the specific one, converts it to this NAPQI intermediate step before using glutathione and getting rid of it. This is the toxic metabolite that causes all the liver injury. And what happens is you use glutathione in the process of getting rid of this NAPQI, and this is why N-acetylcysteine, which repletes glutathione, this is why it's used to kind of shunt away all the NAPQI into a non-toxic conjugates in the liver, or away from the liver, eventually into the urine. And so just a demonstration. So this is the patient, right? And gets the ingestion here of Tylenol. You get, liver enzymes will keep going up until you give the NAC. And then once you give the NAC, things start improving, hopefully. If they don't, they need a transplant. All right. So when you biopsy people with acute acetaminophen toxicity with severe liver injury, you will see one specific thing that we should remember. If this is the liver, so you've got the portal vein here, the central vein here. This is the pericentral area, zone 3. And you can see, you can appreciate, I don't know, it's probably not very evident, but pericentrally in zone 3, there's massive necrosis. All these hepatocytes are lost. You kind of look at it, it's blurry, you can see there's loss of hepatocytes here. It's all necrosis. So zone 3 necrosis is the specific word that you're looking for in the question. And in terms of who gets NAC, practically real world, everybody's getting NAC, right? Who benefits the most is, this guy, Romak and Matthew. They looked at the people with acetaminophen toxicity. They looked at the hours post-ingestion and what was the level of Tylenol in the blood, and they plotted it, and they said these people died, these people didn't die, and they drew a line between those who died and those who didn't. And they said people above this line probably have very high toxicity, and so they moved the line a little bit down to make it more safe, and they said treat these and don't treat those. And this is what we call the Ramak-Matthew nomogram. You can use it to say maybe you don't use NAC, especially if somebody NAC can cause, NAC is a lot of volume you're adding to the patient. Somebody has heart failure or something, you want to avoid volume, then you can use it. You can use this to kind of triage who gets it and who doesn't. Just a bonus question, right? Two patients, patient A, patient B. Patient A is a 27 male who came to the ER after ingestion of 10 grams of Tylenol. Patient B ingested 10 grams Tylenol plus was drinking 3 pints of vodka while ingesting. Which patient has a better outcome? Vote, you guys want to vote? No? So if you down Tylenol with alcohol, would that give you a better outcome? The obvious
The choice
answer,
B.
I'm sorry?
First person.
First person will have better outcomes. The obvious answer is yeah, patient A probably has a better outcome. In real world, no. In fact, alcohol acutely has a protective effect on acetaminophen hepatotoxicity. The reason is because alcohol is actually, in a way, inhibits CYP2E1. And if you remember, CYP2E1 is the one responsible for converting acetaminophen into NAPQI. And in a sense, patient B really has a better outcome than patient A. It's an important tidbit. However, people with chronic alcohol use, it's not going to protect them, because this is acutely, when somebody acutely drinks alcohol, not with somebody with chronic alcohol use. All right, case number 7. 64-year-old female with history of ITP on steroids. Presents now with unintentional weight loss and right upper quadrant abdominal pain. Her liver tests were actually normal, but the ultrasound shows multiple hepatic masses. You end up doing a triple phase CT. This is arterial phase, this is portal phase, this is hepatic phase. So you're seeing a lot of kind of, things are lighting up, a lot of things that are lighting up during the portal phase, right? So these multiple, what looks like masses almost, throughout the liver. So you end up doing a liver biopsy, and the liver biopsy shows a severely dilated sinusoids, as well as some sinusoidal occlusions with loose fibrous tissue, and a little bit of perisinusoidal fibrosis. You see it here, trichrome stain. What is this entity? What is the diagnosis? Anybody came across this? It's a tough one. I think it's probably very, very rare, but this is proliferation of the sinusoids, essentially. And when you have proliferation of the sinusoid and dilated sinusoids, like this pictures here, this is called pileosis hepatis. And this is proliferation sinusoidal hepatic capillaries that result in cystic blood-filled cavities distributed randomly throughout the liver. This is specifically associated with anabolic steroids, sometimes contraceptives. And again, azathioprine is popping up here, and specifically for Bartonella infection, people with HIV can cause this. This may be due to hepatocellular necrosis, the underlying mechanism, or a little bit of veno-occlusive disease similar to SOS. And a lot of these people, or most of these people, are asymptomatic, but sometimes these sinusoids, these big sinusoids start compressing the bile ducts and can cause jaundice. The treatment is usually again, de-challenge, stop the medication that is inducing, there's steroids or there's azathioprine, or treat the Bartonella or whatever underlying cause if found. Any questions about this? All right, move on. Case number 8, a 63-year-old male with hyperlipidemia and type 2 diabetes recently had otitis media 45 days ago. Now presents with pruritus, jaundice, and dark urine. You do the labs. AST is 70, ALT is 82, ALK-Phos is 311, and the T-bili is 31. And the rest of the labs are normal. You do a liver biopsy, and the liver biopsy shows brown stuff. What is this brown stuff?
Bilirubin.
Yeah, exactly. So you've got cholestasis, essentially, evidence of cholestasis. You also have a little bit of periportal lymphocytosis. So this is essentially cholestatic hepatitis. So what is the diagnosis?
Delhi.
Dilly. What's the D? Amoxicillin?
Amoxicillin-induced cholestasis.
Amoxicillin.
Or amoxicillin. Yeah.
Is it really amoxicillin? Anybody wants to change? It's not amoxicillin.
I've been with the second before.
Augmentin. Yes, Augmentin. Somebody said Augmentin. It's Augmentin. It's amoxiclav. It's not amoxicillin alone. It has to be Augmentin. Okay. So this is a very common one. You probably will see it in real life. Again, this is an idiosyncratic reaction that can happen anytime. This happened 45 days. It can happen months later. Predominantly causes a cholestatic injury, although can cause mixed and hepatocellular injury. One important thing to remember, there is a specific HLA class 2, this DRB1 1501, that increases the risk for developing augmentin-induced liver injury. Supportive care alone is enough, like any other cholestatic liver injury, and you can use ursodiol or cholestyramine if symptomatic. The important point here is 2 points. Number one, do not re-challenge with Augmentin. It's going to recur. If you want to give an antibiotic, you can safely give amoxicillin alone, and it won't cause it. So if you want to treat H. pylori, knock yourself out.
Well, Mohammed, I'm sorry. So, you have the HLA classes. I'm sorry, but I just, how about the elderly? I just avoid it very much in the elderly as a whole because they have much more likely chance of getting this. I get nervous when I get prescribed Augmentin in anybody, but definitely in the elderly. And you're not going to go checking this HLA class. I know for the boards you need to know this, but I don't think anybody's doing that before they start Augmentin. So is that something you looked up and reviewed?
I didn't see a specific age association like any other drug injury. They talk about, age being a risk factor for a lot of things, for a lot of these drug-induced liver injury. Specifically for Augmentin, I didn't see like a cutoff. It's not like fluoroquinolones and like tendon injury. They talk about the age. At least here, I didn't see something like that. But it could be. It may as well be because again, age can be a risk factor.
I remember reviewing a paper that it said that elderly, but it could be that there's other confounding factors. Maybe patients that are elderly are more medications, statins or anything, and maybe they just have a worse outcome. Nobody really knows.
Definitely.
I don't know how you could study that.
What I saw is that polypharmacy is one of the main important kind of risk factors for somebody developing drug-induced liver injury.
Just one word on the HLA class. And now that we are doing the whole genomes, we will be using these HLA haplotypes, and Dylan Network is collecting extensive data on HLA classes associated with medications. We are using it in some HIV medications currently, but this is going to become more of the mainstream as we can really haplotype everyone. We will be picking up medications depending on this HLA haplotypes. That's coming soon.
Nice. Thank you, Dr. Eiderman. Do I move on? Few slides left. Okay, case number 9. So 57-year-old male presents with chest pain, found to have VTAC, was admitted to the CCU. He was originally on amio, PO at home, but then during his course was switched obviously to a IV infusion in the CCU. Now has the following liver enzymes: an AST of 4,000, an ALT of above 2,500, an ALK phos of 108, and a TBILI of 0.77. So what is your differential diagnosis here? It's a typical thing that comes to mind right away. So 57.
Hemodynamic instability is one.
Exactly.
But then acute immune toxicity as well.
Yeah. So 2 things, right? It's going to be either shock liver or, unlikely develop acute hepatitis all of a sudden, but it could be related to the drug, right? So it could be shock liver or amio-induced toxicity. The amio-induced toxicity is very interesting. So there's 2 forms of amio-induced liver injury that we should know. Number 1 is IV amio, has a different kind of toxicity that we see here. This is IV amio toxicity. and it presents more of a similar pattern to ischemic hepatitis. It's very high elevated liver enzymes, very hepatocellular injury. Sometimes it's really impossible to differentiate whether this is shock or this is amio. So really safest to stop the amio. The mechanism is not really clear, but they're saying it could be related to the mixture of the IV amio because they mix it with other things rather than the amio itself. You can switch safely to PO amio in people with IV amiotoxicity like this. However, you should also remember that PO amio has its own liver injury. This is distinct from the IV form. This really happens on the long term. It's a chronic toxicity and mainly manifests histologically by microvesicular steatosis that is slowly developing. It's not acute microvesicular steatosis. It's slowly progressive microvesicular steatosis that eventually can lead to micronodular cirrhosis. And the challenge is usually the treatment is usually de-challenging the medication, stopping the amio, and this takes years to improve sometimes because it's a slowly developing injury that takes years to develop. All right, I think this is the final case. So a 15-year-old male has history of seizures on valproate, now presents with jaundice, fatigue, and body aches. Liver enzyme shows an ALT of 248, an ALK phos of 423, TBILI of 15.2, and an INR of 4.1. Before we get into what's happening, this is the famous picture, right? This is the DSEP picture. So what is the difference between both of these pictures? So this is the liver histology, right? Anybody? Balkan on. So this is the hepatocyte, and inside the hepatocyte,
Is it micro and macrovesicular?
yes, inside the hepatocyte there's droplets of fat, and here outside the hepatocyte there's a big droplet of fat. So this is microvesicular steatosis. This is usually related to drug injury, acute fatal liver of pregnancy. So it's inside the hepatocyte. While this one is macrovesicular steatosis. This is NAFLD, right? This is NAFLD-NASH essentially. So it's important if they show you a picture of this. And the reason I mention this is because valproic acid can induce an acute form of microvesicular steatosis that can be pretty severe. This is very similar to when you give aspirin to children. If you give aspirin to children, what happens? What's the famous thing that happens? Or the famous liver injury, the famous syndrome? Race syndrome, exactly. So valproic acid and aspirin in children can induce what we call Race syndrome, which is a acute microvesicular steatosis that can be severe, very poor prognosis actually, and can end up in liver failure. The treatment is supportive, but sometimes may require transplant. So it's very important to keep in mind.
Guys, I'm sorry. Is it Rye syndrome, or I don't remember as Ray's syndrome?
I read it as Ray. I don't know the specific pronunciation.
R-A-Y is Ray. Rye syndrome. Anyway, just making sure I have the right diagnosis because you got me there.
Yeah. All right.
By the way, is there Mallory bodies on that last histology that I thought I saw? Any Mallory bodies? Is that right or no?
These things?
Maybe on the left slide. On the left slide.
Oh.
Yeah. Are those little things there? And
it could be. I'm not sure. These, yeah, you're right. It could be because sometimes you can see Mallory bodies in microvesicular steatosis and hepatitis. You're right. All right. So just I'll go through these quickly. We kind of talked about most of them, but again, there's clinical and histologic phenotypes of DILI, right? This is again from the same article. Is a very nice table that gives you all kind of the clinical phenotypes of drug-induced liver injury and the type of liver injury that can be associated with it: idiosyncratic, direct, or indirect, and a little bit about latency and the typical agents. Again, this is just kind of for you to go over. I'm not going to go over all of it. It's interesting to know that there's a difference between cholestatic hepatitis, which is induced by augmentin, and bland cholestasis, which just means cholestasis inside the liver without the induction of hepatitis. Again, these are two different things. And histologically, again, if you look histologically, there's different patterns. It can be acute or chronic hepatitis. You can get acute cholestasis, granulomatous inflammation, which we didn't talk about. There's micro and macrovesicular steatosis, and zonal necrosis. This is a famous one, acetaminophen. Halothane is another one that can cause zonal necrosis. So the question is, how do you diagnose DILI? How do you prove that this is DILI? Just a few things we should know. The DILI criteria are really is if you have an ALT or AST elevation above 5 folds of upper limit of normal, or ALK-Phos 2 folds, or a TBILI 2 folds with an ALT and AST that is 3 folds. And the famous thing to do specifically if you have an idiosyncratic drug reaction, not really if you have a direct or indirect toxicity, but if you have these drug reactions that happen anytime and you're not sure what's happening, you can calculate what we call the R factor to try to differentiate between hepatocellular, cholestatic, or a mixed liver injury. And this is advocated for in the latest ACG guidelines. And if you're too lazy to calculate, you can use the table I made. Just plot the ALT and ALK-Phos and gives you the R factor, and gives you if mixed, cholestatic, or hepatocellular. And this will help you to know, to kind of triage what next steps you need to do to try to tease out if this is drug-induced liver injury or something else. The question that always rises, we're not going to go too much into this, but how do you know that this is drug-induced liver injury, not something else induced liver injury, right? How do you prove causality? And this is made by what's called the RUCAM method, or this method really has a number of points that you can take into account, and then if it's above 9, then it's highly probable that the drug caused the hepatocellular or cholestatic or mixed injury. Another thing we should...
The RUCAM is hardly ever used because it's pretty old and it doesn't have even hep C in it, viral hepatitis in it. So, but you can see it still in some of the articles.
Yeah, I think for RUCAM, it's important to understand the concepts behind it more than actually going through and calculating a score.
Yeah, exactly. You should just know kind of how they tease out causality, essentially, rather than really memorizing the score, because you always have access to the score. The other one to know is this thing called Hy's law, and Hyman Zimmer, I think. Anyways, Hy's law essentially says, it's a bunch of, a lot of wording, but the bottom line is, if you have a hepatocellular type of injury that is associated with jaundice, with high TBILI, this is poor mortality. This is poor prognosis, up to 10% mortality rates. So if you have hepatocellular injury and then the TBILI starts going up, bad. That's what you should know.
So there is one more caveat there, though. The ALK-Phos is not elevated.
Yes.
AST/ALT goes up with bilirubin, which is what we call hepatocellular jaundice. That has the poorest prognosis. Like in augmentin, what you showed us, ALK-Phos and AST/ALT goes up, that's going to come down and that patient is going to do better. But once you have acute hepatitis with AST/ALT, no ALK-Phos elevation, and then the bilirubin and INR starts going up, that's where you have minimum 10% mortality immediately.
Yes, exactly. It can be up to 10%, exactly, up to 10% mortality. It's pretty bad. I was going to go over immune checkpoint inhibitors hepatotoxicity. It's pretty important to know, but I think we're kind of running out of time. I'll kind of zip through it. The bottom line is that these are first of all, hepatotoxicity from immune checkpoint inhibitors is rare, but it depends why you're using it. If you're using it for HCC versus using it for non-HCC, then there's a higher incidence when you're using it for HCC. You have higher level of hepatocellular injury. The underlying mechanism is really kind of unknown, but they think about it as two different mechanisms. As we said, it's either direct hepatotoxicity or a drug-induced autoimmune hepatitis. And when you do the biopsy, it can show one or the other. It can show an autoimmune hepatitis-like reaction. Again, this is just a nice table that differentiates both of them. We don't have time to go over it, but it's important to know that the latency of this is really 4 to 8 weeks. And once it happens, if there's no improvement, you can actually, this is a nice algorithm about what to do. You can start steroids for these patients. And then if there's improvement, you can actually resume the checkpoint inhibitors if improvement. You have to really try everything, and nothing works until you say permanently discontinue ICI. Again, we don't have really a lot of time to go over it. I just want to brush over these ACG guidelines from 2019 about DILI, and just important things to remember about these is that they differentiate. There's 2 different algorithms for hepatocellular mixed DILI versus cholestatic DILI. As we said, use the R factor. For hepatocellular or mixed DILI, you want to check all the hepatocellular hepatopathies, the hep A, B, C, autoimmune hepatitis. You really want to check an HCV RNA sometimes, because sometimes people don't mount an antibody. And to that point, you can check an anti-HEV IgM, hep E, but then this can be falsely negative if people post-transplant or somebody is immunocompromised. So really, you need to check the HEV RNA levels for these people. They recommend testing CMV and EBV or acute or HSV essentially. And then finally, they recommend evaluation for Wilson's, Budd-Chiari with an ultrasound. For the cholestasis, they really recommend abdominal imaging, specifically an MRI and MRCP, and testing for PBC with an AMA. And then finally, they have like their nice algorithm that they put in at the end. You start by calculating the R factor. Well, first of all, talk to the patient, do your physical, and do your drug, review all the medications. But then, you do your R factor, and then you kind of proceed as the previous table. Just final take-home points. So you've got, remember, NRH, which is nodular regenerative hyperplasia. This can end up with non-cirrhotic portal hypertension. The liver might look nodular, but it's non-cirrhotic. Remember azathioprine as a culprit. SOS, sinusoidal obstruction syndrome. This is the veno-occlusive liver disease. This is post-hematopoietic stem cell transplant that you can use URSO for prophylaxis. Also remember, Jamaican bush tea, but also can be due to other medications. Drug-induced autoimmune hepatitis can present with positive ANA, but also can be seronegative, and it may need a biopsy to prove. But the culprits are usually minocycline, infliximab, nitrofurantoin, and remember that once you start steroids, don't stop until the resolution. DRESS, remember the rash, remember the eosinophils, remember the fevers, and remember allopurinol and the Han Chinese population. Statins are okay in compensated cirrhosis, not okay in decompensated cirrhosis. Acute Tylenol plus acute alcohol, protective. Remember this tidbit. And pileosis, which is the dilated sinusoids, remember the anabolic steroids can cause it. Cholestatic hepatitis, Augmentin, supportive care, nothing to do. All right, you can use amoxicillin instead. And then IV amio, shock liver. PO amio, can cause cirrhosis eventually, but really better outcomes than the IV amio. And then finally, you really use clinical judgment, use R factor, use liver tox, right? This is like this is my favorite. You just go on, and this, even if you think you know it, they really keep updating the things, and it's nice to read it every time.
Mohammed,
yes.
I need to run to another meeting, but I cannot tell you how much I enjoyed this. The kids outgrow the parents. I can see that here. You could give this talk for the ACG, really.
Thank you.
All that hard work playing around with your software really paid off.
Thank you, Dr. Heinemann. Really appreciate it. Anybody has any questions?
Excellent job.
All right, thank you, Dr. Dillon.
Yeah, Mohammed, that's great. I like your simulator. You should have a little bit of a statement saying this will be a simulation, not a diagnostic tool. It's like whatever, something like a disclaimer or something like that. But it's very good. You could probably get it published. Why don't you publish it?
Yeah, eventually, once it's ready for prime time. You should use artificial intelligence.
My daddy,
drug.
I'm like daddy quote, quote or whatever. I don't know, something like that. That's great. Very good job. Excellent.
Thank you so much. All right, guys, enjoy the rest of your day. Good luck scoping and seeing consults.
Good job, Mo.